Hello, everyone. My name is Shadi Reyes. I'm the co-host for this activity. I'm really privileged to be with esteemed speakers for this webinar. This is a series of webinars that DMC have put together to increase awareness of cardiovascular disease in the community for education, as well as to offer services to referring physician and as a showcase for what we do at DMC. My second speaker is going to be Dr. Yusuke Terasaki. He is a cardiothoracic surgeon. He's also a graduate from Johns Hopkins University in cardiovascular and thoracic surgery.
So I wanted to kind of start off with a personal anecdote because I was one of the, I guess, unfortunate ones who came down with COVID earlier in March. So the last week of March, I began having this profound fatigue, so much so that I was having difficulty getting out of bed and getting to the bathroom, which is right next to the bedroom. I had diarrhea for a couple of days, and I've never experienced any headaches in my life until this time when I started having these recurrent headaches, intermittently actually for over 3 months or so. And over just 2 months, I started not having headaches, but I've been having these headaches for a long time. However, unlike some of the other patients that showed up in the hospital, I actually did not have any respiratory symptoms. I was not having any coughs. I did not have any fevers. I did have a travel to Nashville in a large group environment, and my significant other that I live with also tested positive for COVID-19. But after a couple of days, all the symptoms resolved, and I felt better. I quarantined myself for a week, and then I went to work. Let me see if I can go to. So a month later, I started having this swelling in the back of the throat, and one day I woke up and I just could not breathe when I was laying flat. So I went straight to the emergency room here in Harper and got a CT scan. I was diagnosed with a peritonsillar abscess. This is actually the CT scan of my head, and you can see this abscess that's compressing my airway. And I had one of the ENT residents come over and emergently drain the abscess cavity that you can see on the right side of the picture. So I think there is definitely a lot of asymptomatic patients like myself, or very little symptom patients that, like myself, opened up later on. And anyways, I am one of many in Michigan who came down with COVID. As you can see in this picture, there's about 114,000. This is up to date up to yesterday. 114,000 patients here in Michigan, mostly located in the Detroit metro area, around Oakland, Macomb, Wayne counties. And this is the chart. So when I got sick, this was the end of March. So this is exactly when the surge happened earlier this year. And then there's the trend down. And then when the summer hit and everybody was going around their business, you can see that there was another slight surge towards the end of June. And it's been kind of plateauing down again thereafter. And as you can see from these graphs, you can see that this virus is disproportionately affecting people who are of older age, above 80, and of people of African American descent, as you can see in the graphs on the right. It's definitely affecting men and women equally. And this is some data from our hospital system. So from left to right, this is Children's, DRH, Harper, Sinai Grace, and Huron Valley. And you can see that there is a total of about 3,000 cases throughout the system, and about 700 cases in DRH, Sinai Grace, and Harper. But when you look at the next graph, these are the number of deaths from COVID that we saw in our hospital system. You can see that it has disproportionately affected Sinai Grace. Whether that's from racial inequality, I don't know for sure, but there's definitely some inequality here in terms of the number of deaths per cases that have been seen in our hospital system. And this is another pie graph showing the same thing. So purple here is the Sinai Grace number of cases as a proportion to the rest of the hospital system at DMC. And in terms of deaths, it actually encompasses almost half of it. So there's some inequality here that I don't quite understand why it is, but it has happened. And so when you see this kind of solemn data, there's no wonder why a lot of patients would come up to you and ask you and be worried about coming to the hospital to be taken care of for other issues. Sorry, this is another data that's coming from our hospital system with the number of COVID cases in our different hospitals and number of patients requiring ventilator. And as you can see, if the patients go on mechanical ventilator, percent of the patients have passed away from that. So this is a really bad disease, especially for patients with respiratory symptoms who get really sick and who end up on breathing machines. And no wonder why, our patients are asking, should they be coming to the hospital? Should they be worried if they have an elective case that is coming up? Should they wait? So let's look at, this is specifically to cardiac surgery now at the DMC. We have performed a total of 133 cases since COVID hit up to now. And of those 133 cases that we have performed, only 3 patients were diagnosed with COVID-19 post-operatively. 2 came towards the end of March or mid-March when we didn't really know too much about COVID at that time. And 1 came later during that second surge in the summer in August. All 3 patients are now discharged. There were no mortalities, these patients who were diagnosed post-operatively. I did see 2 asymptomatic COVID positive patients preoperatively. And for these patients, since they were completely asymptomatic from the COVID, and they were they had very little symptoms from their cardiac issues as well, we actually sent them home for a couple of weeks, and then they came back with a negative COVID result before we proceeded to performing elective procedures on these patients. So there are very few people, since COVID hit, amongst our patient population who ended up having COVID positive. So what are the ways that we are, doing in the OR and the ICU to prevent, our patients from contracting this virus? Well, number one, in the preoperative environment, all the patients have to have a negative COVID test within 72 hours of surgery. So whether they go to their own, closest hospital or clinic, or they can come to our hospital to get tested, they have to all have a negative test before we can proceed to surgery. Obviously, some of these patients have difficulty going to another clinic or hospital because of transportation issues. So these patients can actually come to our preoperative area, and we can do a rapid PCR test on these patients that will result within an hour. And if it's negative, then we can proceed to surgery. Now, in terms of the OR, we have decided in the hospital system that non-aerosolizing procedures can be performed in a normal pressure room as opposed to a negative pressure room. We did have, during the peak season of COVID, 2 negative pressure rooms in Harper OR for performing aerosolized procedures such as tracheostomies. However, I had spoken to the OR team yesterday, and they had actually since then gotten rid of the negative pressure rooms since we had so few patients with COVID positivity in the OR. And all the staff must don proper PPE, face shields, including an N95 mask when they are involved in any cases with COVID patients. So I think Dr. Zair had touched a little bit about tracheostomies, but we did perform these procedures. Tracheostomy is basically a procedure where we perform on patients who end up on breathing machines. The long tube that we have placed on these patients are high risk for later on. So we try to place these patients what's called tracheostomy tubes, which are these tubes that go directly into the airway through the neck to prevent that risk of infection. And traditionally, this is performed in an open fashion, where they go to the OR, and they can large incision in the neck, dissect down to the airway and put this tube in. But over the last decade or so, there's been a new technique called a percutaneous tracheostomy tube placement, which we decided was probably less aerosolizing than performing an open tracheostomy approach. And that's the method that we've been using to perform tracheostomies on our patients. And across the hospital system, we've performed about 44 tracheostomies. And in Harper itself, I think we performed about 20, and majority of those, our team, the cardiac surgery team, performed the tracheostomies on. And we had preferred to do these at the bedside since these are really quick procedures. As long as we have the dedicated team to perform these procedures, it's a really simple procedure. And so we decided to perform these procedures within the ICU units instead of bringing the patients over to the OR, even though there is a negative pressure OR rooms in the OR. We decided that it's probably safest to actually perform these patients, these procedures in the ICU, which would prevent them from having to transport the patients through clean areas of the hospital, through the elevator shaft, exposing healthy asymptomatic patients from the virus. And in terms of the procedure, we perform it percutaneously using cell-denture technique and dilatation to minimize aerosolization, as we talked about. And again, we perform this by a dedicated team, simply consisting of a surgeon, an assistant, and an anesthesiologist, all wearing and donning appropriate PPEs. And here is a picture of one of our dedicated anesthesiologists wearing the appropriate PPE during our tracheostomy placements. And on the right is a depiction of how the percutaneous tracheostomy is performed. And as you can see, it's really just a needle through the airway, so there's really no concern for droplets escaping this area.
Yusuke, just for the sake of time, you have a couple of minutes.
Sure. Okay. All right. So in the ICU, all the COVID patients are placed in COVID units or in isolated ICU rooms. The nurses and all the staff are using face shields, N95s, and gowns. I'm going to show you a picture of this as well, but the IV poles that are hooked up to the patients are actually located outside of the ICU door to prevent unnecessary entry and exit of staff into the rooms. And ICU staff, whenever we perform these tracheostomies, remain outside to prevent any contraction of the virus. And Dr. Zare mentioned about the ECMO, so I'm not going to talk about that too much. And this is a photograph of one of our COVID patients that we have right now. And as you can see, the patient is inside the ICU room, whereas the IV pole that's hooked up to the patient is actually outside, so that nurses can titrate the drip without having it. These are some of the ways that we're protecting the staff from the patients. And so what's the data? So we have 9 ICU care unit where the nursing has to see all our postoperative cardiac patients, and they're the ones who are also taking care of all our COVID ECMO patients. There's I think 40 nursing staff at the moment, and these patients are day in, day out, 24/7, interacting with these COVID patients, and only 3 actually contracted COVID-19. They're all asymptomatic and doing well. And amongst the floor staff, the step-down units, there were actually quite a bit more. Almost half of the nursing staff and the PCAs actually contracted COVID-19. We don't really know where that came from, but it's interesting to know. And then one of our people also tested positive for COVID-19 aside from myself. But again, back to with all these staff contracting COVID, only 3 tested positive for COVID-19, and this was early on in March when we really didn't know too much about this disease process. And I want to end with this photo of the cardiac surgery team going to get tested for COVID antibodies. Everybody was convinced that since they were around me pretty much every day in, day out, that they had contracted COVID-19 as well. And surprisingly, not a single one pictured here had PCR positive or antibodies, and they're the ones who've been really working with me day in day out, throughout this COVID era. And so I think the learning point from this is that as long as you're wearing a mask and washing your hands and wearing your protective PPEs, we are well protected, and as well as the patients who are coming here to get their elective cases.
I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.